Welcome to our channel. Today, we have a gripping case that every healthcare professional should be prepared to handle. A 28-year-old agricultural worker is rushed into your emergency department. He's drenched in sweat, saliva drips from his mouth, he's vomiting, and you notice muscle twitching across his body. His vital signs are alarming. Heart rate, 48 beats per minute. Blood pressure, 85/60ths of a millimeter of mercury. Respiratory rate, 12 breaths per minute. Pupils, constricted. So, here's the challenge. What is your differential diagnosis? How would you manage this patient urgently and effectively? Introduction to organophosphates. Definition: OPS are chemicals used as pesticides and nerve agents. Composition: phosphorus acid and carbon derivatives. Routes of exposure: inhalation, ingestion, dermal absorption. Relevance: significant chemical threat due to widespread use. The image shows the chemical structures of different organophosphorus pesticides classified based on their chemical groups. First, we have the diethyl organophosphates. A parathion. This is a thioate with a diethyl group and a sulfur atom attached to the phosphate. Parathion needs to be converted into its active oxon form, paraxon, to inhibit acetylcholinesterase. B-paraxon. Paraxon is the active oxon form of parathion. It can directly inhibit acetylcholinesterase without further activation. See quinalphose. Quinalphose is another diethyl thioate organophosphate with a sulfur atom attached to the phosphate group. It also requires conversion into its active oxon form. Next, we have the dimethyl organophosphates. D-monocrotophos. Monocrotophos is an oxon organophosphate. It has dimethyl groups attached to the phosphate and can directly inhibit acetylcholinesterase without needing activation. Finally, the S-alkyl organophosphates. E-profenophos. Profenophos is an S-alkyl organophosphate with a sulfur atom linked to a propyl group. It can directly inhibit acetylcholinesterase upon absorption. F-prothiophos. Prothiophos is another S-alkyl organophosphate. It has two chlorine atoms and a sulfur atom attached to the phosphate. It needs to be converted to its active oxon form. Pathophysiology. Mechanism: OPS inhibit acetylcholinesterase. Leads to accumulation of acetylcholine. Overstimulation of cholinergic receptors. Affected systems: neuromuscular junctions. Central and peripheral nervous systems. Additional point: respiratory failure due to intermediate syndrome may develop even after initial stabilization. Clinical features: muscarinic symptoms. Mnemonic is DUMBELS. Diarrhea, urination, meiosis, bronchoria, bronchospasm, bradycardia. Emesis, lacrimation, salivation. Effects: increased secretions, bronchoconstriction, bradycardia. Nicotinic symptoms: neuromuscular signs, muscle fasciculations. Weakness progressing to paralysis. Autonomic signs: sympathetic, mydriasis, tachycardia, hypertension. Parasympathetic, bradycardia, hypotension. Central nervous system effects. Symptoms: confusion, agitation. Seizures, status epilepticus. Respiratory depression. Mechanism: excessive ACH leads to neuronal excitability. NMDA receptor involvement and glutamate release. Intermediate syndrome. Timing: 24 to 96 hours post-exposure. Incidence: occurs in 10 to 40% of cases. Features: cranial nerve palsies. Proximal muscle weakness. Respiratory insufficiency. Mechanism: dysfunction at the NMJ due to prolonged AKE inhibition. Delayed neuropathy. OP-induced delayed polyneuropathy, or OPIDN, occurs weeks after exposure. Symptoms: distal weakness, sensory deficits. Cause: inhibition of neuropathy target esterase. The vital points regarding butyrylcholinesterase assays are: butyrylcholinesterase inhibition does not indicate poisoning severity but helps detect exposure to organophosphorus or carbamate pesticides. Butyrylcholinesterase levels recover by 7% per day once the toxin is eliminated, so daily monitoring can indicate recovery. Variations in commercial assay kits can cause up to 30% differences in results. Temperature control is crucial. Butyrylcholinesterase activity increases by 4% for every 1 degree Celsius rise. Red cell acetylcholinesterase assays. Red cell acetylcholinesterase inhibition correlates with poisoning severity and is a better marker of synaptic function. Acetylcholinesterase recovers slowly, less than 1% per day, which is much slower than butyrylcholinesterase. Blood samples must be diluted and cooled immediately to avoid ongoing reactions and inaccurate results. Oxime treatment effectiveness can be guided by red cell acetylcholinesterase assays, especially to decide on continuing or adjusting oxime therapy. Ensure airway, breathing, and circulation are stable. Place the patient in the left lateral position, with the head lower than the feet, to reduce the risk of aspiration. Provide high-flow oxygen, and intubate if necessary. Administer 1 to 3 mg of atropine intravenously, depending on severity. Set up an infusion of normal saline, aiming for systolic blood pressure greater than 80 mm of mercury and urine output greater than 0.5 ml per kilogram, H. Record vital signs, pulse rate, blood pressure, pupil size, sweating, and chest sounds, before and after the first atropine dose. Administer pralidoxime chloride, 2 grams, or obidoxime, 250 mg, intravenously over 20 to 30 minutes, followed by continuous infusion of pralidoxime, 0.5 to 1 gram per hour, or obidoxime, 30 mg per hour. Reassess after 5 minutes. If no improvement, give double the original dose of atropine and continue doubling every 5 minutes until clinical parameters improve. Continue atropine boluses until heart rate exceeds 80 bpm, systolic blood pressure exceeds 80 mm of mercury, and chest sounds are clear. Tachycardia is not a contraindication. After stabilization, start an atropine infusion, 10–20% of the total stabilizing dose per hour. Monitor frequently for signs of over- or underdosing, that is, cholinergic symptoms or atropine toxicity. Continue oxime therapy until atropine is not needed for 12 to 24 hours, and the patient has been extubated. Monitor respiratory function. Intubate and ventilate if tidal volume is less than 5 ml per kilogram, vital capacity is less than 15 ml per kilogram, or if PAU2 is less than 60 mm of mercury. Assess flexor neck strength regularly in conscious patients. Weakness may indicate intermediate syndrome, which requires immediate attention. Treat agitation by reviewing atropine doses and using benzodiazepines for sedation. Avoid physical restraint due to the risk of hyperthermia. Monitor for recurring cholinergic crises, which may occur due to release of fat-soluble organophosphorus from fat stores over several days or weeks. Retreatment with atropine and oxime may be needed. Key factors in organophosphorus, OP, pesticide toxicity. Toxicity. Human toxicity varies, even for OPs with similar RAT-LD50 values, e.g., parathion is highly toxic, timefas is safer. Impurities. Storage in hot conditions can produce toxic byproducts, as seen with malathion. Formulation. Toxicity depends on how the pesticide is formulated, e.g., malathion concentrations vary by region. Alkyl subgroups. Dimethyl ops age acetylcholinesterase faster, requiring quicker oxime treatment. Atypical groups may render oximes ineffective. Activation. Many ops need conversion to active oxins via P450 enzymes. Fat solubility. Fat-soluble ops like fenthion act slowly and cause prolonged symptoms, while non-fat-soluble ops like dichlorvis act quickly. Onset. Symptom onset varies. Rapid inhibitors like paroxin can cause unconsciousness within 20 minutes. Adjunctive therapies are benzodiazepines, control seizures, provide sedation. Magnesium sulfate may reduce ACH release. Potentially decreases ICU stay and atropine requirements. Sodium bicarbonate, alkalinization may enhance oxime efficacy. Limited supporting evidence. Newer and investigational therapies. K-oximes, newer ACE reactivators with broader spectrum. Potentially more effective than traditional oximes. Hemoperfusion, removes lipid-soluble, protein-bound OP compounds. May reduce symptoms and complications. Fresh frozen plasma, serves as a biological scavenger. Controversial efficacy, more research needed. Prognosis and long-term outcomes. Potential morbidities, depression and anxiety disorders, cognitive deficits, recurrent seizures, follow-up care, neurological assessments, mental health support. Additional point: long-term cognitive and psychiatric effects are common, and follow-up care is essential. Prevention strategies, regulation of pesticides, stricter controls on OP availability, education, training for safe handling and use, protective equipment, gloves, masks, and protective clothing, community awareness, recognizing early symptoms for prompt treatment. Key takeaways for managing the poisoning are: early recognition, prompt identification of symptoms is critical. Timely intervention, immediate administration of antidotes improves outcomes. Monitoring, regular assessment of vital signs and neurological status. Prevention, reducing exposure is essential in managing public health impact. Thank you. If you liked our video, do subscribe and share.